What is dementia? Dementia is a general term for conditions involving loss of cognitive function that interferes with activities of daily living. If you'd like to learn how to assess and manage dementia from a primary care perspective, be sure to watch this video until the end. Alzheimer's disease is by far the most common cause of significant cognitive impairment, but many factors may influence cognitive decline. Memory loss is a complaint often reported by a family member who has observed a decline in cognitive function. The patient may not have awareness of the cognitive impairment. Your next patient is Mr. Smith, age 65 years old, whose daughter requested an appointment. The daughter's concern: her dad has become more forgetful over the last 3 months. Mr. Smith has been losing his keys. On a few occasions, he forgot to turn off the stove. How will you approach this consultation? Taking a collateral history is very useful in assessing cognitive impairment. What questions would you like to ask Mr. Smith and his daughter? When evaluating memory loss, it is important to determine whether the patient truly has a memory disorder or another cognitive problem. Depression may present with similar symptoms to dementia in older adults. Cognitive impairment includes memory loss, problems with reasoning and communication, difficulty in making decisions, dysphagia, difficulty in carrying out coordinated movements such as dressing, disorientation, and an awareness of time and place. Some patients may present with impairment of executive function such as difficulties with planning, judgment, loss of initiative, and problem solving. First and foremost, you may start by exploring the presenting complaint. Ask about the memory loss. Inquire about the onset. Was it an acute onset, subacute, or chronic? Ask about progression. Has there been a slow progression of the memory impairment or stepwise progression? Ask about behavioral and psychological symptoms of dementia, also known as BPSD. These include psychosis, agitation and emotional lability, depression and anxiety, withdrawal or apathy, disinhibition, motor disturbance, sleep cycle disturbance or insomnia, tendency to repeat phrases or questions. These symptoms tend to fluctuate. They may last for 6 months or more. Explore the psychosocial impact of the cognitive decline. These include difficulties with activities of daily living. In early stages of dementia, this may lead to difficulty carrying out complex household tasks. In later stages, basic activities such as bathing, toileting, eating, and walking become affected. Inquire whether the patient is driving, as there may be implications to fitness to drive. Assess the risk of cognitive decline on the patient and others. If the patient is wandering and may get lost, if the patient is leaving gas on or is exposed to abuse, neglect by himself or others, the risk of aggression. These are important elements of the history. Be sure to cover drug history, as some commonly prescribed medication are associated with an increased anticholinergic burden and may cause cognitive impairment, for example, Benzodiazepine, anticholinergic drugs, and opioids. Inquire about family history of dementia, ask about alcohol or drug use, elicit the patient's ideas, concern, and expectation, and the relative's idea, concern, and expectation. Based on your history, you may be able to make a working diagnosis of the subtype of dementia. This could be Alzheimer's disease, vascular dementia, dementia with Lewy bodies, or frontotemporal dementia. The most common subtype of dementia is Alzheimer's disease. This usually presents with a loss of memory associated with difficulty in executive function and nominal dysphagia. Patients tend to forget recent events, so there is a loss of episodic memory. They may ask repeated questions or may have difficulty learning new information. Other cognitive deficits may include aphasia, apraxia, and agnosia. In vascular dementia, there is a stepwise deterioration in severity of symptoms. Patients may also present with focal neurological signs. Clinical features of dementia with Lewy bodies include fluctuating cognition, recurrent visual hallucination, REM sleep behavior disorder, and or more symptoms of Parkinsonism, such as bradykinesia, resting tremor, or rigidity. Memory impairment may not be apparent in early stages. In frontotemporal dementia, patient may present with a change in personality and behavioral disturbance such as apathy, social or sexual disinhibition. Differential diagnoses of dementia include mild cognitive impairment, delirium, hypothyroid disorder, depression, normal pressure hydrocephalus, sensory impairment. If you suspect dementia, NICE recommend to conduct a physical examination, including a neurological examination, to look for coordination and gait abnormalities, sensory findings such as peripheral neuropathy, motor symptoms such as hemiparesis, tremor, rigidity, or bradykinesia. Look for visual or auditory problems. Look for cardiovascular signs such as hypertension, arrhythmia, or peripheral vascular disease. Other possible causes of symptoms such as physical or mental illness. Cognition can be assessed by various cognitive assessment tools such as 10-point cognitive screener, the 6-item cognitive impairment test, the 6-item screener, the memory impairment screen. NICE recommend arranging appropriate blood tests to exclude reversible causes of cognitive decline. These include full blood count, ESR, CRP, UNEs, calcium, HbA1c, liver function test, thyroid function test, serum B12 and folate levels. Further investigations for suspected dementia to assess structural changes include MRI or CT scan. NICE recommend cognitive stimulation therapy, a range of activities and discussion that are aimed at general improvement of cognitive and social functioning. Group reminiscence therapy. This uses objects from daily life to stimulate memory and enable people to value their experiences. Cognitive rehabilitation or occupational therapy to support functional ability. According to NICE, pharmacological treatment for cognitive symptoms should only be initiated on the advice of a specialist. Treatment may be continued in primary care under a shared care protocol. First-line treatment is an acetylcholinesterase inhibitors. These include donepezil, galantamine, and rivastigmine. Second-line treatment is memantine, N-methyl-D-aspartic acid receptor antagonist. Advise patient on fitness to drive. Group 1 license holders may be able to drive but must notify the DVLA. Group 2 license holders must not drive and must notify the DVLA. Consider providing fact sheets on driving. For example, Alzheimer Society website provides one that might be useful to help patients decide when to give up driving. All drivers with dementia must eventually stop driving when dementia becomes moderately severe and in many cases earlier. If you found this video useful, then I've got another video where I talk about how you can take a psychiatric history. If you'd like to learn how to take a psychiatric history, then watch this video. Thank you for watching this video until the end. If you have any questions or any suggestions for future videos, please comment below. Take care everybody. Bye bye.